Hello, everyone. I'm Sue, and this is Amy Britt. She's out in the hall right now. We are your region leads for Soft Bones Hypophosphatasia Foundation. As a lead, we are here to answer your questions with our HPP experts and your hosts for this regional meeting of the Southwest area of the United States. The Southwest region isn't only Arizona, but California, Hawaii, New Mexico, Nevada, and Utah. Amy and I would like to welcome everyone to the 2022 Soft Bones Southwest meeting that we have long awaited for. We wish we could have invited everyone in person like previous years, but thankful that technology, we can experience each other virtually while we learn and bring awareness to hypophosphatasia. I would like to keep this brief, but before we can begin, I have a few housekeeping announcements. For those of you in person, please mute your cell phones now. We are recording this session for the viewing from a device. You will be automatically placed on mute and will not be able to unmute yourself. This is to optimize the quality for the presenters. When you have a question, please type them in the Q&A box located at the bottom of your screen. Be aware we may not be able to answer all your questions today due to time restraints, but we will pass them on to the appropriate presenters after the meeting. Note, today's meeting is not a telemed session. Therefore, we cannot answer any specific medical inquiries. While we encourage you to ask questions, they will be answering them in a broad sense and not specifically towards personal care. For those of you who don't know about Soft Bones or aren't familiar with it, Soft Bones is a 501c3 nonprofit. We are based as a patient advocacy group dedicated to the community of patients, caregivers, and families living with hypophosphatasia. Our mission is we empower the HPP community through education, awareness, support, working with patients and medical communities, and also policymakers. Through our funding, we also support research and new therapy options for patients, as well as gene therapy. For healthcare providers who would like to learn more about HPP, consider contacting echo@softbones.org. I would like to remind everyone today about the agenda. Sorry. That was mailed to you. I would like to say that we are partially sponsored by Alexion Pharmaceuticals for this presentation today, and we would like to thank them. Now, without further ado, I welcome our first presenter, Dr. Pamela Smith. Sorry, there's the agenda. I'm sorry, people. Dr. Pamela Smith. Dr. Pamela Smith joined Endocrinology Division at PCH and has focused on developing PCH growing multidisciplinary skeleton health clinic. Dr. Smith completed her training in pediatric endocrinology and metabolic bone disorders at Washington University in St. Louis and the Center for Medical Bone Disease and Molecule Research at Shriners Hospital for Children in St. Louis. She is also clinical assistant professor for the Department of Children's Health, University of Arizona College of Medicine, Phoenix. Her clinic and research interests include pediatric bone disease such as osteogenesis imperfecta, X-linked hypophosphatemia rickets, hypophosphatasia, fibrous dysplasia, vitamin D deficiency rickets, and secondary osteoporosis. I would like to welcome Dr. Pamela Smith.
Okay. Well, welcome everyone. We're excited that we could all be here, whether in person or virtually. It's been a long journey with the pandemic. So I'm so excited that we could be meeting after at least 2 years, right?
Yep.
So excited we can have some people here and excited to have a virtual audience. I'm honored to speak today on behalf of our Skeletal Health Clinic and just want to welcome everyone. So I will be discussing hypophosphatasia, a journey through genetics, features, and therapies. I have nothing to disclose. So let's just run through our objectives, like kind of what we're going to discuss during my session. Understand hypophosphatasia and its genetics, and define the features and types of HPP. Explore the diagnosis and evaluation of the disorder, and discuss when to consider aspartate alpha therapy and risk versus benefit. Explore complications of HPP, including treatment versus not treatment, and then discussing other aspects of HPP management, which is a multidisciplinary approach in an ideal world, though not always readily available, as many might know. So HPP is a rare genetic condition that affects bone and teeth mineralization with a wide spectrum of severity, as we know. Multiple organ systems are affected beyond teeth and bones. 1 in 100,000 births in North America are affected, with severe HPP. And the gene carrier status, meaning those who carry the gene but are not affected, maybe as much as 1 in 250 to 500 people or 300 people. Sorry. So we'll talk about the gene that causes HPP. So ALPL is a gene, it's the name of the genetic, the gene that's affected by causing genetic condition. And genes are basically an instruction manual for your cells in your body. So you can think of genes as, the DNA is your library, and then the gene is the book in the library. So ALPL is the book that is effective in HPP. So there's lots of functions in ALPL, but 1 or 2 changes that aren't typical. And it can be autosomal dominant, meaning there's 2 copies or 1 copy affected, and that's most people. And then there's recessive, meaning there's 2 abnormal copies or atypical copies of this gene. You have 2 genes, 1 from each parent. So you have mom's gene and your dad's gene. So 1 gene could have it, or 2 genes could have this gene change causing HPP. Usually kids with more severe forms often do have 2 copies affected. So life-threatening HPP suggests autosomal recessive inheritance, and there are over 330 mutations identified so far in ALPL. So what causes HPP then? The ALPL gives instructions for tissue, a mouthful, tissue, non-specific alkaline phosphatase. You know it as alkaline phosphatase, ALP, alpha. So lower alpha activity occurs in the body. This alpha is not produced as much, or is not as effective. And there's a buildup of other products because of that. ALP is involved in some mechanisms in the body. And if it's not working, you have this buildup of products that it was supposed to help with and break down. So we have pyrophosphate, which is a strong inhibitor of bone mineralization. That builds up. So obviously you have a buildup of strong inhibitor of bone mineralization. That's a problem. You're not going to mineralize your bones. Then you have POP, which is a circulating form of B6 that cannot so POP is a circulating form of B6 that cannot cross the blood-brain barrier. And B6 needs to cross the blood-brain barrier because B6 is involved in neuron activity. So if B6 can't cross, then that leads to B6 seizures in some infants. So this is often seen in severe infants that are HPP, which we'll talk about. So as far as features of HPP, it's the severity, it's the spectrum of the disorder. So there's no one person with HPP is like another, right? We're all unique. So each individual needs personalized medicine for that reason. And then so you think of it as a spectrum. You can be a gene carrier, meaning you have the gene, but you're not clinically affected, you don't have symptoms. You then, if you're moving mildest, and very mildest to most severe, then we have odonto HPP. And odonto is basically just primarily teeth are affected. Then we move on to adult HPP. There is some thought that odonto later presents as adult HPP, and that's adult onset, meaning we didn't really have much as far as symptoms until adulthood. And then we have childhood, so you present earlier. And we have infantile, which is even earlier, basically as an infant, and then became that perinatal form of HPP, where it's obviously in utero, or it's always reproductive. So clinical symptoms include developmental delay. We're going to talk about all this in more detail. But developmental delay and voice growth in children often occurs. Respiratory difficulties, especially in severe forms, when babies are born with severe HPP. They may need to be placed on a ventilator. Skeletal disease, obviously, dental issues, primarily premature tooth loss, and that's often a trigger for dentists to refer or primary care doctors to refer. And muscle weakness, a lot of muscle weakness, difficulties walking, performing daily activities, neuro problems, neurologic symptoms, and even kidney issues from calcium deposition, calcium deposits in the kidneys. So this is just some images showing some of the clinical features of HPP. For the first upper image A, this is the MRI of the skull of a 6-year-old individual with HPP, showing cranial synostosis and a resulting bump on the top of the head there, where the sutures intersect, where the sutures come together. So the sutures are the soft spots, right, that we see on babies. So those often close early. The image B, the image right below, is a 4-year-old with HPP with undermineralization. The bones are not well mineralized. And it looks like a copper beaten, they call it copper beaten appearance to the skull. C is deformity of the lower extremity, with joint widening. It's very classic. At the knees and elbows, and this is actually a 15-year-old with severe HPP. B is a knee radiograph of the same individual. He shows knee radiograph of the same individual, showing intramedullary rod in the tibia, and a fracture line is actually seen in the middle of the tibia where the yellow arrow is. So even though there's a rod there, there's still fractures their leg. E is actually the bone under a microscope. So this is from a bone biopsy, and it's a stain showing basically a normal versus HPP bone. The normal is at the top, and the HPP bone is the picture below. So This is actually someone who's an adult, and there's an accumulation of osteoid, meaning precursor to bone formation. That's that little pink, hot pink kind of outline on the edges. There's a lot of osteoid, but it kind of gets stuck in that phase, and it doesn't get minerals. It doesn't get calcium, it doesn't get phosphorus. And the picture above, you can see that filled in, that hot pink border filled in with bone. So that is ability to treat on another picture. As far as G, this is a photograph of a 2.5-year-old showing premature tooth loss of the lower and incisors. And then in H, this is the teeth coming out, and it shows roots intact, which is hallmark of HPP. And then I is just a lady of a 20-year-old doing extensive dental work of HPP. So this is a busy slide that we'll just kind of go through a little quicker. So this basically, depending on the patient age, signs, symptoms, complications of HPP, including bone issues in utero, which is my bone issues present then. You can have premature tooth loss at less than age 5 through tap, or bone mineralization, fractures, musculoskeletal pain, respiratory problems, impaired growth, poor mobility, vitamin B6 seizures, cranial synostosis, and in some cases, early death. So we have on this slide, it talks about perinatal HPP, which unfortunately is typically lethal in utero, or soon after birth. And severely poor mineralization of the skeleton. I honestly didn't even put a picture because I feel it's really bad. So that and we feel it's very helpful for us today. So let that out. And then B6 seizures often occur. Unexplained fever that we're not sure why. Hypoplastic or underdeveloped lungs, and then we can have intracranial hemorrhages, strokes, basically. And then if we move to the next severity, childhood, yeah. So I went in that order. So childhood, the next severity actually would be infantile, which is before 6 months of age. We pass the birth period, infantile HPP. They do usually do well if they get treatment very, very early. And that's typically the activated alpha. And we'll talk about what adjustments have been made by activated alpha in infantile HPP because they classically do not make it into their older years. So before 6 months of age, these kids have respiratory difficulties. They have some of the same features as perinatal. Failure to thrive with poor feeding and muscle weakness, delayed milestones, cranial synostosis, elevated blood and urine calcium levels, not going into the bones, and B6 seizures. Childhood HPP happens after 6 months of age. So a lot of HPP is classified by when it's apparent. Was it right at birth? Was it within 3 months? Was it 1 year, 2 years old? Was it adulthood? Teenagers. So that's how it's classified as well as severity symptoms. The child occurs at the age 6 months, and often they have premature tooth loss. There's a broad spectrum, even in childhood, severe to mild. And there's still fractures, muscle weakness, delayed milestones, waddling feet, very common at both legs, knock knees, swollen joints. Rickets on joint x-rays, so you might get worked up for other things, other forms of rickets, and growth delay, short stature, cranial synostosis for them as well. And then adult HPP often presents in middle age, and some have early tooth loss, actually, like in the childhood period. And they have lots of also secondary teeth, recurrent metatarsal or foot fractures, very classic. So adult HPP presents with foot fractures oftentimes and then difficult to heal. Pseudo fractures can occur. It's almost like a pre-fracture. Or we can talk about it better than not quite fully grasping pseudo-fracture, what that is, but I'm sure we can ask them. But it's kind of like a fracture, kind of, it looks like a fracture, it's an undermineralization, the bone has a weakness, it's not coming properly. So it looks kind of like a fracture. Chondrocalcinosis, meaning you have calcium deposits in the cartilage, so that can be like a joint. And that obviously is arthritis. And pseudo-gout also occurs from deposition of some of the products that belong in the bone, going in other places. So we kind of went through most of this. We talked about the perinatal. There is a form that's very interesting called the non-prenatal. I don't really see it or talk about it a lot. Where there's findings of HPP in utero. There's even both limbs effort, but spontaneous improvement occurs after delivery. But it has been noted they could develop maybe adult HPP later on, or late childhood or mild HPP. So it's a very interesting form of HPP. And we talk about childhood. Usually it presents at ages 2 to 3. So just around 2 to 3. And I really think that these kids, I think they're more mobile. And they're walking and they're running. You might notice a lot in the gait, you might notice fatigue, you might notice their muscle strength not quite as it should be. And then we talked about the other ones. So this is actually a radiograph of an X-ray of severe HPP, someone with severe HPP. So no, there's no accident. So on the left is, so I'm trying to show an example of severe versus odonto. Odonto is tooth only, so we're feminine only. So on the left is odonto, and on the right is severe HPP, or childhood severe. And you can see the gradual severity as you look left to right, and how the image gets kind of worse as you go. So A shows subtle changes that's in the head of the fibula. So the fibula is that tiny little bone, the small bone below the knee, that little thin slender bone. The top of that is kind of blurry. That's really the only sign of that HPP in this odonto. And then there's B, mild childhood HPP, which shows tons of radiolucency, which is classic terminology for HPP. Basically, it's a shadowing. Try to point. This is a very common term used in articles. So, yeah. I know it. So, that's the kind of radiolucency, that red circle there. And it's kind of like just a darkness, right by the joint. Very, very common in the joint. And then in severe HPP, our last image, you will see severe blurring and loss of the borders of the bones, and even the time of radiolucency, the whole thing is gray and washed out. So, and then as far as diagnosis, you know, it can be quite expensive. But really it's a clinical diagnosis first, okay? Because there are carriers of HPP, low alkaline phosphatase. Some people have a mildly low alkaline phosphatase and they're asymptomatic, they're not symptomatic, they might be a gene carrier. So oftentimes gene carriers have a mildly low alkaline alkaline phosphatase level. But what we should look for are the features that we've been reiterating as well. You know, hypomineralization of the skeleton, deformity, bone, short stature, long pain. Just all of the things we kind of were going through before growth and development delays. And then, you know, on your molecular, in your lab work, right? That's where it often gets picked up as well. You should have low alkaline activity, meaning it's measured low. So it will be within, not within the normal range for your age and your gender. And we also want to rule out other causes for low alkaline phosphatase. So is there malnutrition? Is there another disease present? Even kids who are on steroids can have a low alkaline phosphatase. So there are other, you know, causes that actually we want to pick up first, or we consider treatment for HPV. So that's why an adventure to get treatment for HPV. And then you can confirm things through genetics, right? You can get a gene test. Now there's a great free test out there through a company who's an specialist about it. That is still a lot of common, sort of more common, not more common. So more common forms of skeletal dysplasia. So yeah, so symptoms first. At least you have to have one symptom present with a low alkaline phosphatase level. And I always confirm it. There's lab errors. So I need to make sure it wasn't something with the lab. So as we talked about, low alkaline adjusted for age and gender and at least one sign or symptom. So there should usually always be premature loss of the primary teeth with the root intact, meaning the tooth falls out before age 5. Oftentimes, what I trained with said it would be painless slipping of the teeth, just slipping out. Oftentimes, the parent will just find it because it wasn't painful, so the child may not complain about it. Rickets. So there should be in a child, I should add. So we don't really have rickets in an adult because the blood plates are closed. So rickets is present in children in HPV, and there's tons of videos you see that shadowing the shirt around the joint. And then pseudofracture, that would be present more likely in an adult or an infant. And then the other symptoms we talked about. And then some folks might elevate to a B6 level because we're not able to convert it and get it into to cross the blood-brain barrier. So you will usually have a higher B6 level than so one should be considered as a replacement. What does different systems mean? We should consider it as clinically indicated with some symptoms of severity, but not simply that. But it is not an easy treatment, and we will talk about that. And I have had to start and stop therapy for children, and yeah, we'll talk about the pros and cons. So the sub-Q, meaning small injection, not into the muscle, kind of like insulin, if you know, insulin. The sub-Q injection freezes kind of the and we consider it for an adult, because there's a lot of questioning on whether we do this for an adult. For children, there's much more obvious reasons. They're becoming delayed, they're rickets, they're maybe their time walking. But for an adult who's, you know, at the surface level, getting around okay, and when do we decide to start treatment in an adult? So if there's pain requiring prescription medicine, pain medicine, that's when you consider it. If there's disabling joint, right, to the point you can't get around. Disabling functional level, like doing daily activities is hard. If there's a low trauma fracture, meaning you weren't in an accident, you didn't fall from the stairs, you stepped off the curb wrong, you bumped something, that's a low trauma fracture. Delayed incomplete fracture healing. So if you have the knee, you won't heal. That's something you have to think about it. Repeated surgeries for HPP bone disease. So if we're having to go through a lot of procedures, that's definitely a time to think about study medicine. And then in the bone density, probably most of us have all had bone density, and it would be in the osteoporotic range, which is less than almost 2.5 in women and men, and then for the kids it's -2. So there's actually a higher cutoff in children. And then we also want to think about it with male patients who have fractures or hypophosphatasia. So if there's calcium in those kidneys, something to think about. So, the alpha has shown major improvement in all areas of living, and has shown physical function and improvement in physical function and quality of life. It's shown improvement in X-ray findings, meaning that some of the abnormalities will improve or go away. Pain has improved. There's been long-term follow-up in children and adults, and they've shown drastic improvement in many of the symptoms related to HPP. It's not a cure, so we can't expect basically to reverse everything. It's not a cure, but it is a really good therapy for those who need it. So there's been shown there's healing of cellular changes, there's improved growth, only after 6 months of therapy. So all it takes is being on it for half a year, and if it's helpful, it will show it's helpful. And if we're giving it and doing it the right way. It has reduced the mortality in the first year of life in perinatal and infantile forms of HPP. So survival in infants with seizures went from 100% mortality to 77%. So there's hope, right? If you were an infant with seizures, there was not hope. So here's a index for challenges before and after therapy. So on the left, you will see X-rays from a 15-year-old severe childhood HPP, and 6 months after therapy is on the right. On the left, there's marked signs of breakage bone, so fraying of the ends of the bone. You can see there's like that shadowing. It's not so really bright with the rest. You'll see that, and then that's where the tongue of the lucency as well. And also on the right, you'll see that is almost gone away. It's those tongues and that washing out of the bone at the end of the bone is the out as it's nearly gone. So, things to consider. So, everything comes with a, something to think about. Adverse effects. So, the most common adverse effect is an injection site reaction. And see it in children and adults. And it occurs in like most people. 3/4 of people have, skin changes. There might be temporary redness or almost like a bluish appearance to the area, purplish red. It might be painful and it could be swollen. And then there's over time this chronic loss of fat under the skin. And that's called lipohypertrophy or lipoatrophy. So usually what we see is a loss, but there has been also where it's fat deposits. And it looks like these lumps where shots are given. So, and those take a very long time to go at all. So it could be, a permanent change to the way there are no medical orthotics. So that's why it's often important because this is a direction we want to go. And then you can have allergic action. Anaphylaxis is like any other drug. So things to consider: risk of allergy, which is the medication, scarring, skin changes secondary to the injection, potential to develop an immunity against aspartate cells. So you can become resistant to it over time. I haven't seen it a lot on my end, but that's why it's important to give only the doses needed. If you give higher doses than needed, you're subjecting the body to higher levels, and you give them potential to build antibodies against the medication. So it's important to pick a dose that is effective but minimal. And then benefit of improved function and quality of life and mental health. So those are the perks. So you have to weigh the average effects versus the benefits. There's other therapies that have been tried. I did want to give kind of some mention. Other therapies that have been tried. Teriparatide shows some improvement in most case reports. It only can be used for 2 years. Teriparatide is parathyroid hormone, basically. Parathyroid hormone that basically it mimics your own parathyroid hormone. Parathyroid hormone is really important to mineralization of those. This has been tried, but it really can only be used for 2 years or so. And it cannot be used in children. It's actually black box, meaning they don't know in Livingston. So it has shown, because it showed in juvenile mice to show tumors at the bone. So because in juvenile mice they had some tumor growth, we don't use it in children. And then bone marrow transplant is another thing that has been tried with intermittent success, and that comes with a lot of unwanted things as well.
Back
to the pictures. This is an example of the skin reaction, but this is a really good summary. So it just looks like a welt, almost like I think it would be metal orange. This is kind of how it looks to me. And then it can get this purpley kind of look to it. So, and it can be permanent. So definitely something to think about, especially a child, you know. And then as far as multidisciplinary care, super important, hard to get, but super important. And it should be a coordination of medical providers. And it can include obviously a pediatrician or family medicine or general practitioner, orthopedist, neurosurgeon, dentist that understand what HPP is. I'm finding actually more dentists know about it than sometimes other providers. Pain management specialists, so they are really important as kids get older. And therapies, PT, OT, speech, eating therapies, even important. NSAIDs are also used for pain and inflammation. There's other pain management strategies, which our pain team will talk about later this afternoon. And then renal ultrasound should be done. It's becoming less, and aspartate alpha has helped improve mineralization, but people do it every 3 to 6 or 12 months. And really the interval depends on if you are to have calcium or not. If you don't have calcium in the kidney, we're not going to keep doing everything else we do again. And then orthotics, for especially those with foot fracture. Orthotics are like bracing most limbs. And then I did forget to mention, which we won't go back, that genetic counseling too is going to be a real important thing. So this is just a really cool picture of what a team might look like for someone with severe HPG. You can go around the wheel, and as you go inside the wheel, those are becoming more and more important specialists. So the more the center is as a patient, right? And then you have a coordinator. And we actually do here at Children's, Children's, we do have a care coordinator who oversees multidisciplinary care for kids with rare bone disease. And his name is Bill. I'm just going to give him a shout out. And then as you move out of the loop, this is your core specialists, endo, genetics, ortho, the therapies, and then as you move out, some others that are also important. And then as far as older children and adults, that you see your web gets a little smaller. How it goes, everything goes from a child to an adult. Again, the core is your patient, always the core. And then you move out, you definitely an endo. Some rheumatologists, in all fairness, I want to give credit, should mention probably a rheumatologist. Some rheumatologists are managing HPP. And then ortho, big time. And then maybe therapies and genetics might be important for family men. And then to move out with your other specialists, definitely pain specialists. I think pain specialists might want to actually move in a little bit, but those sometimes are hard to find. That's probably why it's on the algorithm. All right, so that is pretty much it on my end. Any questions that anyone has for me?
Is your treatment with aspartate alpha over time? We know that aspartate alpha, is it intended to be lifelong once you start, or is there a period of time after your bone is remodeled that you don't need to continue with it? What's the thought?
Yeah, so the question was if you're on the therapy, is there a point where you might be able to come off the therapy if your bones are not up in the heels? And you know that applications with that, especially if you move from childhood to adulthood, you can do a trial off of therapy and see if, because the bones aren't growing and turning over as rapidly, so it's more sustained. So there has been movement toward trialing off as you're done growing and see if that helps. I think it's really symptoms and it's a multi-factor. So looking at the bone density scores, are you in the normal range? Are you high? Are you overdoing it? Symptoms, are the symptoms going away? Or is it coming back? It's really, you got to think about what a lot of factors. Unfortunately, more than individual basis, I would say, rather than, an endpoint.
You mentioned developing an immunity to aspartate, which I love hearing that too. I like trying to think that that's one of your learned years ago. What are some things they look for when they're looking for building an immunity?
So the question was for the webinar audience was if you build immunity, how do we assess for that? How do we know we have immunity against disease? So basically it's you're going up and up on the dose from what I've seen. It doesn't happen that much. It's very uncommon. Okay. If you're going up and up on the dose, great adherence, getting every injection as you should be. If we're going up and up on the dose and there's not imaging improvement with the imaging findings are not improving, symptoms are not improving, then you're like, okay, what is going on here? Unfortunately, there's not a standardized test to test for it, which is a bummer. It's research-based. So you have to really maybe even talk to cell phones. Sometimes when I have unusual questions, I may reach out to them as a resource to see how to navigate or even a Alexion should be able to help maybe if there's concern with that. But yeah, unfortunately, it's not standardized test for it.
There's a question on here. Will lipid dystrophy go away if you stop injecting at that site?
So lipodystrophy is very hard to get rid of, unfortunately. It can't go away. I would say almost 8 years. So it's kind of here to stay. But it can go away. I would say it depends how bad it is too. So if it's really severe, the chances are much lower.
Next question is, do you recommend genetic counseling for adult children with HPV?
So the question was if there's genetic testing and genetic counseling for an adult with HPV.
Yeah, like her kids are already adults.
Okay. So, yes, well, it depends. So if you feel like you might have HPV, then for sure. If there's family planning, like if you're planning to have children, then for sure you might want to meet with a genetic counselor. But really the genetic counselor would be, for anyone, it's to see if you're affected or if your children or other family members are affected. So if it's already been established that the children have it, unless we're family planning and having more family members, siblings, then you may not need to.
Next question. For a child with genetic confirmation, but not many symptoms, about 2 years old, what should I look out for?
So not symptoms,
Not many.
but has genetic confirmation. So the question was about genetically confirmed HPV in a 2-year-old, not many symptoms. First of all, I would say we need to get in with all the specialties if there's any symptoms, because you have clinical HPV. So there's clinical and then there's genetic. Clinical means you are affected. So I would get in with ortho or an endocrinologist familiar with HPV, because that child should be monitored closely.
Is speech delay part of HPV in children?
That's a really good question. That's a great question. Not she's there now. So yes, HPV, the kid that often has speech delay, definitely in the more severe forms, and even feeding trouble. So a lot of oral versions and feeding issues, and the early loss of teeth. You need your primary teeth for enunciation. So if you're losing off your front teeth, it's a lot harder to learn to talk and to speak clearly. So, yeah.
There's one more. Okay. How low is, okay, she says, the Z-score. Her doctor's not clear at what point does it indicate clinically diagnosed.
Okay, so there's T-score and Z-score. T-score is an adult, you're 18 or over. And the T-score is anything less than -2.5. And Stu's going to take it in the show live answer for you. Z-score is what we use, I know, we're just going to talk about here. Z-score is in children, and that is anything less than -2.0. So the cutoff's a little higher. But anything below those, I think of them as degrees of temperature. Anything more cold than -2 or -2.5, then yep, you're in the osteoporotic range or low bone steering. Make sure it's adjusted for height. It's a very overlooked thing. And in HPV, we have short stature oftentimes, or shorter stature. So there are ways to adjust for height.
Is there an approach recommended for patients with HPV, not arthritic, but also has osteoporosis?
So the only things that have been tried are the other therapies I mentioned, teriparatide. You could consider teriparatide, parathyroid hormone. I will type that in the chat later because it's a really awful word to spell. So it's teriparatide is a drug that's also injectable, so bummer. Not getting away from shots. So that's probably the only other thing you do not want to get